And good morning, good afternoon, good evening to everyone. My name is Todd Tuttle. I'm a surgical oncologist at the University of Minnesota and co-leader of the Global Breast Cancer Seminar. We're very excited about today's presentations. Before we start, I do want to make an announcement, and that is that our global surgery or our University of Minnesota Global Breast Fellowship applications are now open as of today. This is a one-year fellowship in breast cancer training that's only open to physicians from low and middle income countries. The requirements are that you've completed all of your training, that you've passed step 1 and step 2, and that you are absolutely committed to going back to your home country to improving breast cancer outcomes there. So there'll be a link in the chat, and I'll mention it again at the end of the presentation. But if you have any questions about this fellowship, it's a multidisciplinary fellowship. You rotate through surgical oncology, plastic surgery, medical oncology, radiation oncology, breast radiology, pathology, genetics. We have you do a research project as well. So it's pretty rigorous, but amazing experience for you. So I hope you can consider applying. I'd like to introduce my partner, Dr. Jennifer Morgan, who is a medical oncologist here at the University of Minnesota, and she will get us started.
Wonderful. Thank you, Todd. Thank you, everyone, for coming today. It's my pleasure to introduce our two speakers today. So first we'll start with Dr. Joanna Hunter-Squires. So she's an assistant professor of clinical surgery from Indiana University. She received her medical school training and residency at Indiana University and breast surgery fellowship at Cedars-Sinai in Los Angeles. She practices as a breast surgeon at Indiana University, and she has a passion for global surgery and surgical education. I met Dr. Hunter-Squires while she was spending 3 years working in the AMPATH partnership in Eldoret, Kenya, where she was doing quite a bit of breast cancer surgery capacity building. And again, really a focus on surgical education and some simulation, apps, modeling, and she's really done a lot of very cool things in that space. And she will be talking today about nodal management first, really from a surgical perspective. And secondly, we have Dr. Jianling Yuan. She's an associate professor and vice chair for education in the Department of Radiation Oncology at the University of Minnesota Medical School. She works as a board-certified radiation oncologist and specializes in the treatment of breast cancer. And she's been a key contributor to advancing evidence-based approaches in breast radiation therapy. She completed her medical school degree and PhD at Yale, and her residency in radiation oncology at the University of Minnesota. She has many clinical and research interests, including optimizing breast radiation techniques, hypofractionation, and node management, which she'll be talking about today. She's been recognized many times as a top doctor in Minnesota and has been awarded for her clinical excellence. So it's such a pleasure to have you both, and I think this is a great time to kind of talk about nodal management from surgical and radiation oncology perspectives. So thank you both, and we'll have Dr. Hunter-Squires begin.
Hello, everybody, and thank you for inviting me to be here, Drs. Morgan and Tuttle. I think this is always a daunting topic to discuss. It's probably one of the most complex areas in current breast surgery. And interesting also to try to condense down and focus. And I have no pertinent disclosures. And, I'm a surgeon, so I am pretty simple. I like to think of things in really direct ways. So my options as a surgeon taking care of breast cancer are really three. I can do no axillary surgery, I can do a sentinel lymph node biopsy, or I can do an axillary lymph node dissection. And there are some subtleties to this. And, sentinel lymph node biopsy has expanded a little bit. And we talk about, well, we do a sentinel lymph node biopsy first. We see pathology results from those lymph nodes. And we may follow that with a completion axillary lymph node dissection. And then we have another gray zone, often called the targeted axillary dissection, which is really just a sentinel lymph node biopsy with removal of a previously marked node that's known to have had metastatic cancer in the past. Still, this is fairly simple, but if we take our axillary surgical management in the context of other management of the axilla, it starts to become really complex, and the surgical decisions don't lie alone. And so we think about what is the interplay between the surgical decision and the radiation, which we'll talk about later today, whether that's, comprehensive nodal irradiation or just whole breast radiation, where some of the lower axilla is covered, or does this include partial breast irradiation or even no irradiation? And also in the growing context of ever more complex systemic therapy, and where a lot of the evidence generated to help us make decisions about surgical management of the axilla were done on patients who were largely receiving a lot of systemic therapy. Beyond that, all of us know who practice in the real world that this management is really overshadowed by tumor biology. And, one not aggressive cancer, you could do almost anything or nothing and have a patient be fine. And with a very aggressive tumor biology, that's not the case. And then we have to consider the competing risks to our patients. And this is where a lot of kind of early efforts to de-escalate surgical management of the axilla really focused, is thinking about the slow progression of most breast cancer, and beyond this, all of the management that our patients choose to accept sits in, within their own personal values. And it's not as though all patients come to us and say, "Yeah, I'm going to do exactly what you tell me to." And that wouldn't be right, because patients have different values and so can interpret risks and benefits of surgical procedures in different ways. And at the essence, this also sits at our societal values. And we talk about this, I think, a lot with screening when we talk about, how should we detect breast cancer early, but I think it applies to treatment too. How we perceive both monetary value of our treatment and also for a patient's life. So the goals when we talk about management of the axilla, we talk about, can our management of the axilla impact survival? Hopefully a survival that improves the quality of life for our patients. And then even more than that, we're now talking about precision medicine and helping each patient get the right amount of treatment. And when we talk about these in terms of kind of the evidence that supports these, the topics that we talk about is, how does our local control that we can achieve surgically impact distant control, whether directly by actually removing cancer or by generating an immune response. And then our discussion has also transitioned over the past several decades to talking about staging for treatment decisions. How will the information we get from the axilla lead to different management for the patient beyond surgically? And then lastly, this can provide prognostic information, which can often be helpful for patients, but also for the providers. So I'm a surgeon, so I also have to talk about history. And I think the evolution of surgical management of the axilla is interesting and has been, again, an area where there's still ongoing debates and research. But when we think about the surgical management of breast cancer in general, We have to realize this is one of the oldest described operations is, removal of a breast for breast cancer. And, described in Africa and Egypt, 3,000 years ago, well, more than 5,000 years ago. And so it's been around a long time. And we also know that breast cancer was often fatal in the past, and we see this even today with patients who have no treatment, and really the loss of life and quality of life related to breast cancer is always been impressive and remains so. For an American talking about this, we talk about the father of American surgery is Sir William Halsted, who really has impacted the way that we think about breast cancer and also about scientific data in surgical decision making, and in the 1890s and 1900s. He really pioneered more and more aggressive surgical therapy for breast cancer, leading to radical mastectomy becoming standard of care. And this, of course, included removal of the axillary lymph nodes. And if you look back at his original scientific paper, he kind of coupled this great attention to detail with record keeping, and really was one of the first surgeons to show that he could have patients survive from breast cancer with this radical operation. And this has really impacted the way that we think about breast cancer. And, some of this is not not consistent with modern biologic understandings of cancer, but still, I think surgeons really have this Todd fear of breast cancer, and also a feeling that through more and more radical surgery, we can accomplish something. Obviously, this procedure was deforming, as you can see here in the pictures, labeled Halsted procedure. Not only deforming to the chest wall and breast, but also all of us have seen that an axillary lymph node dissection can lead to lymphedema, and the lymphedema can be a big problem for patients who are experiencing this. And so going back kind of to our timeline here, in the early 1970s, kind of a new era in breast cancer surgery began when Bernie Fisher and ran the national trial, B04, where there was direct comparison for breast conservation. And really, it started kind of a revolution. And as the subsequent trials progressed from that, we saw rapid de-escalation of therapy of the breast and chest wall. But we're still primarily doing axillary lymph node dissections for management of the axilla. And in 1994, Armando Giuliano and his group first started the de-escalation of the axilla, and showed that sentinel lymph node biopsy using isosulfan blue dye was technically feasible and had a less than 1% false negative rate. This was met with a lot of skepticism from the surgical community, and this was not a randomized controlled clinical trial. And so it took quite some time for this idea to progress, that in patients who were clinically node negative and did not have palpable disease, that this procedure could be employed for axillary staging in lieu of an axillary lymph node dissection. And I think even when we had NSABP B32, where we showed no significant differences in overall survival and disease-free survival, the feeling was that this was because sentinel lymph node biopsy could correctly identify patients who had an increased burden of axillary disease. And so again, kind of propelled our thinking about cancer management. And this really changed when the ICASOG Z11 trial came out. And this was a trial for patients with T1 to T2 breast cancers who were having breast conserving surgery, who were clinically node negative by palpation. So the study did not require any axillary imaging, particularly no axillary ultrasound was required. And these patients went on to have sentinel lymph node biopsies, as had become standard of care for these clinically node negative patients. And they randomized patients with 1 to 2 positive nodes without gross extracapsular extension to receive completion axillary lymph node dissection or not, and found that that the 10-year survival was non-inferior in the group who did not have completion axillary lymph node dissection. And I think the reason this was kind of thought-changing was this idea that even though there could be potentially a small percentage of patients with residual axillary disease, that in the setting of patients receiving adjuvant systemic therapy, and in this study, not well described, but probably adjuvant radiotherapy, that additional surgical management only provided additional morbidity. For mastectomy patients, however, when Z11 came out, there wasn't any support for doing the same in patients who were receiving mastectomy. And often those mastectomy patients in a setting where they were not having breast conservation were not planning to have radiotherapy unless their cancer was quite large. And so that was uncommon since breast conservation started with patients with smaller tumors. And so the AMAROS trial was another large trial and included patients who had mastectomy. And these groups were randomized to completion axillary lymph node dissection or adjuvant radiotherapy. And so this was really the trial that allowed us to kind of de-escalate completion axillary lymph node dissections for patients who either needed or chose mastectomy. And in these two groups were no significant differences in overall survival, and the lymphedema rate was considerably higher in axillary lymph node dissection. On their quality of life scales, there were not big differences, but there are other trials that have supported better range of motion for patients not completing axillary lymph node dissection and less pain. So this continued, and surgeons started to ask themselves, what about patients who are undergoing neoadjuvant chemotherapy, who start as clinically node positive and have dramatic responses to their systemic therapy, and convert to clinically node negative in the preoperative setting. And this is another feasibility trial looking at the technical feasibility of sentinel lymph node biopsy in that setting. And similar to initial trials looking at sentinel lymph node biopsy, it's not a randomized controlled trial. It's not looking at survival, but this data was really practice changing. And so in these 700 plus patients who were enrolled in the trial, the sentinel lymph node biopsy was resulted in a false negative rate of 12.6%. And again, this is not perfect, but already Z11 had kind of generated this belief that that residual disease could be treated by other means, but of course these patients have received systemic therapy already, and so I think the idea was that, you don't want to leave additional disease that cannot be treated. And so the big thing to come out of this trial was, well, how could we minimize that false negative rate? And when they looked at subgroup analysis, they could see that patients who had 3 or more nodes retrieved, if the biopsy proven positive node was retrieved, and if both a blue dye and radio tracer were used, that the false negative rate did drop below 10%, which was, their cutoff for acceptability. And so even though this trial was technically a negative trial, it again was practice changing, and is the most common practice in these patients who have access to neoadjuvant chemotherapy and then become clinically node negative. In more recent years, we've even said, well, what is the purpose of sentinel lymph node biopsy for staging? And I think this is really because a lot of decision making can be made by other means when patients have access to genomic profiling. So in estrogen receptor, progesterone receptor positive breast cancer that is HER2 negative, when patients have access to oncotype testing, for instance, a lot of the adjuvant therapy recommendations are made based off of that, and no longer off of the anatomic nodal stage. And so in a setting where patients do have access to oncotype testing, the prognostic and staging significance of the sentinel lymph node biopsy has dropped quite low for those ER/PR positive HER2 negative patients. In a setting where we don't have that information, the information is still really, really vital. But these trials started to say, well, could we get enough information from doing an axillary ultrasound? And so in the SOUND trial, this was patients with cancers up to 2 centimeters who were clinically node negative and planning to have breast conserving therapy and radiation, who then had an axillary ultrasound that was normal. If there was some concern, they had to have a negative biopsy of the lymph node to be able to be enrolled. And then the patients were randomized to sentinel lymph node biopsy versus no axillary surgery. And the outcomes were quite similar between these groups. And so, sorry, I've lost my spot here a little bit. Okay. And so here we go. All right. And so the axillary recurrence risk in the patients having no axillary surgery was also quite low, and the relapse rates were similar between the two groups. This data was then supported by the ENSEMA trial, which enrolled patients up to T2 with up to T2 tumors. So these are some larger cancers, but the majority of the patients, 90% of these patients, were still T1 cancers. And these patients had breast conserving surgery, and they had a follow-up of about 6 years, and invasive disease-free survival between the two groups having no axillary surgery versus a sentinel lymph node biopsy were similar, and the axillary recurrence rates were quite low. And so, and their safety analysis did demonstrate some of the things that we've discussed earlier, with less lymphedema, greater arm mobility, and less pain. And so this has led to, a lot of complexity in the decision making. And as we reviewed, we can talk about benefits for these. So to kind of summarize this, how do we think about this? Well, we need to think about a patient in the context of the treatment that they can and will receive, and really be able to provide them with appropriate options up front. And so there's a lot of necessary knowledge about the health system you're practicing in, and also the patient that you're making treatment plans with. And so the American Society of Breast Surgery has some guidelines, which are several years old, but are quite I think, quite comprehensive about the data that did exist before that time. And I think they make a really good point, which is that we shouldn't do surgery when it won't affect our decisions afterwards. And so when surgical nodal staging is not going to affect adjuvant therapy recommendations, then we probably shouldn't do that. So this can be the case if you have a patient that is frail, elderly, has comorbid conditions that are life limiting, but also it can be in patients who don't have access to additional therapy. They also say patients with DCIS, there's no indication for who are undergoing breast conserving surgery. There's no indication for a sentinel lymph node biopsy. Overall, when we look at DCIS patients, approximately 1% will have nodal metastasis, and this does not justify doing sentinel lymph node biopsy on all those patients. Based on prior studies, which we may discuss when we discuss radiation, patients who are greater than 70 years old with T1 to T2 tumors that are ERPR positive, HER2 negative, and clinically node negative don't need axillary surgery, and nor do they need radiation. And this is a group that is, I think, a very nice place to de-escalate therapy, because we have this supporting data that they may not even need additional radiotherapy. And so it really makes it a nice group where you don't need to spend a lot of resources, and we know that these patients can have very good outcomes. Also, patients with prophylactic mastectomy do not need sentinel node surgery. And then this is the newer group where we said postmenopausal women who are older than 50, who have these T1 potentially to T2, although the data there is less, node negative, estrogen receptor positive, HER2 negative breast cancer with a negative axillary ultrasound, and who plan to receive regional radiation therapy where their axillary staging may be less beneficial. And I think I would add as the caveat here, in patients where axillary nodal staging would determine their adjuvant therapy plan, like would you give a patient chemo if they had positive nodes, then that caveat would be added to this group. Another note from them is that sarcoma and Phyllodes tumors do not need axillary surgery. So sentinel lymph node biopsy is really indicated for patients who are clinically node negative and don't meet the criteria for omission of axillary surgery. And so these are several scenarios where all of that applies. Sentinel lymph node biopsy can be used in the setting of ductal carcinoma in situ, where extenuating features make the risk of nodal metastasis high, and the patient will require mastectomy, where although sentinel lymph node biopsy is feasible after a mastectomy, there's no evidence that that the prognostic information is equivalent. Also, for patients who have recurred after breast conserving therapy and still have a clinically negative axilla, a repeat sentinel lymph node biopsy is indicated. So lastly, it leaves us with patients who need an axillary lymph node dissection. Those presenting with bulky nodal disease initially, which is then biopsy proven, still should probably have an axillary lymph node dissection. Those who fail to meet criteria for Z11 or amorose, so patients who have a sentinel lymph node biopsy where they have more than 2 positive lymph nodes, or potentially more than 3 if they're having a mastectomy based on the amorose trial, although again, less data for 3 or more positive lymph nodes. Those patients should have a completion axillary lymph node dissection. And then similarly, those who are clinically node positive and not eligible or do not have access to neoadjuvant therapy, or they still have palpable disease post neoadjuvant therapy, should have an axillary lymph node dissection. And again, residual disease after chemotherapy is considered therapy resistant, and so surgical therapy is indicated. And then inflammatory breast cancer, where there's no limited to no evidence for sentinel lymph node biopsy due to the high false negative rate. Lastly, an invasive recurrence where a patient is clinically node positive and axillary lymph node dissection is indicated. And those with occult breast primary who remain node positive after chemo. And so to summarize a very complex situation in a few minutes, I think it's an area where you really have to understand a lot about your patient and a lot about your system and a lot about the cancer to be able to help guide them to a correct decision, but where there are a lot of resources to help in that decision making available, and really a lot of growing body of evidence to really help make those decisions.
Outstanding. Thank you very much. That was a very comprehensive presentation in less than 30 minutes. So very well done. We'll have questions at the end. And I think we can have Dr. Yuan go ahead and start her presentation now as well.
Are you able to see my slides?
Yes.
Yeah, great. Okay. I'm really glad to be here. I am Jianling Yuan. I'm a radiation oncologist at University of Minnesota. I work closely with Dr. Tuttle and Dr. Morgan. Today, I'm going to talk about radiation therapy for breast cancer since I only have 25 minutes, so this will be a really quick overview. Let me see if I can advance the slide. I am not sure why the slide is not advancing. All right, so I'm just gonna go to my slide without seeing the Zoom. Are you seeing the outline slide now?
Yes.
Okay, great. So these are all the topics that Dr. Tuttle would like me to talk about. So we're gonna start with radiation management of DCIS. We're gonna move on to invasive carcinoma, touch a little bit about nodal irradiation. Then I'm going to show you the workflow of a patient undergoing radiation. If time permits, I have 1 or 2 slides on the palliative role of radiation therapy for women who present with large fungating breast mass. And so in order for easier for you to follow, so I think most of my slides will kind of be like this. So I'll start out with a clinical question with that emoji there. And then the study, I'm going to put it in a green box so you know which study I'm talking about. And then we're going to talk about some data. And then I'm going to summarize in the take-home message in this salmon-colored box. And then the reference will be provided as well for those studies. So we'll start off with the DCIS. So the clinical question is, what are the treatment options for management of DCIS? So mastectomy is the definitive treatment for DCIS. But because this is a precancerous lesion, non-life-threatening, so active surveillance is currently being studied and potentially appropriate for some patients. For majority of the patients, DCIS is picked up by screening mammogram. So most of them are candidates for a lumpectomy. If they did have a lumpectomy, additional radiation is considered the standard of care. So what are the data for that? So the question of what is the benefit of radiation after lumpectomy in the DCIS setting? There are several randomized trials looking at this. I'm just going to highlight one trial, that is the NSA-BPB-17 trial. So in this trial, women with DCIS who had lumpectomy with a clear margin were randomized to no further therapy or radiation therapy to the whole breast. So this is the 12-year follow-up data looking at the in-breast recurrence. As you can see, with the addition of radiation, the ipsilateral breast recurrence is decreased by about 50%. What's also interesting is to look at the recurrence pattern. So in the recurrence, half the time when women recur, it stays as DCIS, and the other half will become an invasive recurrence. So despite this local control benefit, there is absolutely no difference in survival. And so to summarize, radiation therapy would decrease the local recurrence by about 50% for DCIS, and that benefit is really to reduce a invasive recurrence, which can have the potential to metastasize and potentially needing more treatment. And radiation therapy in the DCIS setting does not impact survival. And because the DCIS is a precancerous lesion, and so we do ask this logical question is, are we overtreating and can radiation therapy be omitted in select patients? So in this ECOG trial, they addressed that question. So they enrolled 2 cohorts of patients. The first cohort is the high-grade DCIS patients. They require to have a relatively small DCIS that's less than 1 centimeter. The second cohort is low and intermediate DCIS that they can have a little bit bigger DCIS. They all require to have at least 3 millimeter clear margin. So no radiation was given, and this study now has had several publications. The most recent one had a 20-year follow-up. So as you can see, that blue line is the high-grade DCIs. They obviously have a little higher risk of recurrence compared to the low-grade risk patients. But overall, even at 20 years, those, the brown line, which is the low-grade DCIS, even at 20 years, the invasive recurrence is only about 10%, which is about 0.5% per year, which is overall pretty low. The other interesting finding from this trial is that the recurrence is related to the size. So if the DCI is greater than 1 centimeter, then at 20 years, the recurrence is about 30%. And that's overall recurrence. And so because of that, NCCN does endorse consideration of mission radiation in patients who meet the low risk, that yellow eligibility criteria, which is low grade, less than 2.5 centimeter, and a margin 3 millimeter or more. So moving on to invasive carcinoma. So in thinking about who will require radiation and what radiation do we give, it's easier, it's helpful to kind of think whether the patient had a lumpectomy or a mastectomy. If they had a lumpectomy, that means they still have intact breast tissue. So radiation therapy to the breast is indicated in most of these patients, but there are some exceptions. So there are data to endorse now. If a patient is elderly, they have small tumor, favorable biology, negative margin, and negative nodes, radiation may be omitted. If they have a mastectomy, they don't have that breast tissue, so surgery is probably generally all they need. However, if they do have high-risk features, such as a very large tumor, usually like more than 5 centimeter, or if they have a positive lymph nodes, especially 4 or more after dissection, these high-risk features put them at a higher risk of local recurrence, and therefore post-mastectomy radiation is generally indicated. So we're going to go over some data on the lumpectomy setting. And so what are the important trials supporting radiation after lumpectomy? Again, there are several very large, good quality trials. I'm going to only talk about the NSABP B06. So in B06 actually is a 3-arm trial, but we're only going to focus on the 2 arms that's comparing radiation versus no radiation after lumpectomy. And they took women with stage 1 and 2 invasive carcinoma that's less than 4 centimeter. At 20-year follow-up, what you can see is the radiation decreased the local recurrence, in breast recurrence by about 2/3. And that benefit is seen in both in lymph node negative and lymph node positive patients. Again, despite that very impressive local recurrence benefit, the overall survival on that left panel is no different. However, there is a marginally significant benefit in terms of breast cancer specific mortality. And so radiation following a lumpectomy does significantly decrease ipsilateral recurrence by about 2/3. That's very consistent of all the studies. And then it is associated with a small but significant decrease in breast cancer mortality. So, and then the early breast cancer trial was cooperative group did a meta-analysis looking at all the randomized trials comparing breast conservation surgery with and without radiation. So when they look at that with more patient numbers, they did confirm that a 2/3 reduction of local recurrence at 5 years did translate into about a 5 to 8% absolute benefit of breast cancer mortality at 15 years. And that does tell us that persistent local regional disease can be a source of distant metastasis and subsequent leading to potentially death, and therefore highlighting the importance of optimizing the local control. So not everybody is a candidate for breast conservation therapy. So what are the contraindications? So these are the absolute contraindications listed by the NCCN guidelines. All of them make sense. So if patient has an inflammatory breast cancer, then lumpectomy is not suitable. If they have diffuse microcalcifications, if you get persistently positive margins despite several re-excisions, if they have a homozygous ATM mutation, because radiation can lead to an increased risk of second malignancies, if they have multicentric disease, or a patient who is pregnant at the time of diagnosis. So as we all know that the local recurrence risk is not equal for all the patients. So some patients may have a lower risk of recurrence, as radiation still needed in everybody. So the CLGB study looked at particularly a very favorable group of women, because we know age is an important predictor of local recurrence. So they took elderly women who 70 or older with a tumor that's less than 2 centimeters. Their invasive carcinoma is ER positive and they're clinically negative, and then randomized them to the standard of care, which is whole breast radiation plus the endocrine therapy versus just endocrine therapy alone without the radiation. So at 10-year follow-up, as you can see, the radiation still significantly decreased the local recurrence from 10% to 2%, but a 10% absolute local recurrence at 10 years is pretty low in this group of elderly women. Additionally, there's no difference in other endpoints, including survival or even a mastectomy salvage mastectomy rate. Because of this trial, NCCN guideline does endorse omission of radiation in women who meet that criteria, and another trial, that's PRIME 2 trial criteria, is also listed there. So there are a lot of ongoing trials really looking at, just like Dr. Hunter-Squires talked about de-escalation of axilla. We do have trials about de-escalating radiation as well. These are the many ongoing studies. And so they have really been bold and lower the age from 70 to even 50. And one interesting feature of these trials is that in addition to the classic clinical and biological features such as tumor grade and size, they really have incorporated the genomic information such as Oncotype DX that's been increasingly used to select patients, low-risk patients suitable for radiation emission. So now we're gonna move on to talking about the data in the mastectomy world. So what are the important trials for post-mastectomy radiation therapy? And so you all know about the Danish trial. So there is a sub-trial of premenopausal women and postmenopausal women. So women who had mastectomy and X-ray lymph node dissection, if they have high-risk features such as tumor greater than 5 centimeters or with positive nodes, they are randomized to systemic therapy alone or systemic therapy with post-mastectomy radiation therapy. So in both trials, they showed, again, there is a 2/3 reduction in the local regional recurrence, but more impressive is there is about a 10% overall survival benefit as shown on this curve. And so post-mastectomy radiation unequivocally really helps with, is beneficial in those high-risk patients, such as large tumor and with positive lymph nodes. However, the Danish trial has been criticized for not performing the best X-ray surgery. So their dissection is considered kind of substandard because they only removed a median of 8 nodes. So that leaves the question of whether radiation is still beneficial in women with a relatively low nodal burden, which is 1 to 3 nodes. So the meta-analysis then looked at all 22 trials of the post-mastectomy radiation therapy and tried to address this question. So this is somewhat busy slide, but we can kind of go to just the bottom line is they found that even in women with limited 1 to 3 positive nodes, when systemic therapy, even when systemic therapy is given, post-mastectomy radiation still benefited these women and leading to a breast cancer mortality benefit. So now on to the nodal irradiation, which Dr. Hunter-Squires already addressed that axilla treatment. So the question then for us is, if a patient has had a complete level 1 and 2 dissection, the surgeons do a good clearance, do you still need to provide regional nodal irradiation? Is the surgery alone enough, or can they still benefit from nodal irradiation? So in this EORTC trial, they took women who either had a positive lymph nodes after dissection, or if they have a high-risk node-negative disease, randomize them to either receiving just the breast or chest wall radiation as indicated, or additionally give them the nodal radiation to the undissected supraclavicular fossa and internal memory nodes. So this is 15-year follow-up data. As you can see, p-values are mostly not significant, not meeting the statistical significance. While they initially showed a improvement in small overall survival at 10 years, and that dissipated by 15 years. However, there's still a very small benefit in terms of breast cancer mortality. And so there is, again, another meta-analysis looking at all 16 trials using individual data to increase the power of seeing something positive. So with more patient numbers, they were able to see, to demonstrate there is a small 2.6% breast cancer mortality benefit if these women receive nodal irradiation. And what they also saw is if for women with more positive lymph nodes, the benefit is larger, and that does make sense. Another interesting feature is that they decide to separate those trials for what they call older trials, which was started before 1980, and the newer trials was initiated after 1980. They only saw that all-cause mortality benefit in the newer trials, but not in the older trials. That probably could reflect that radiation therapy improvements, that contribute less to treatment-related toxicities. And so nowadays, as Dr. Hunter-Squires mentioned, that we often do neoadjuvant therapy for patients who have upfront positive lymph nodes, and that's a good strategy because this will allow us to potentially de-escalate the X-ray surgery and then to tailor the systemic therapy. So in those patients, if after neoadjuvant therapy, if their axilla becomes node negative, is nodal radiation still required? So this is a newly published NSABP 51 trial that just came out in New England Journal of Medicine in June. So they took women with initial N1 nodes who received neoadjuvant therapy and achieved a complete response in the nodes. If a woman had lumpectomy, the randomization is between radiation to the breast only versus radiation plus nodal irradiation. If they had a mastectomy, the randomization is no radiation versus chest wall plus nodal irradiation. And all women actually did really, really well. However, as you can see, the two survival curves really overlap. So in other words, the addition, these women who do so well after neoadjuvant therapy, addition of a nodal irradiation did not seem to further improve the invasive breast cancer recurrence free interval. So this trial is a potentially practice-changing trial. However, as of now, there's still some hesitation among the radiation oncologists due to its short follow-up, and then the subgroups are relatively small in number, and it might be underpowered. So now we're going to move on to something a bit more fun to look at. I have pictures of the workflow and technical aspect of radiation therapy. So when a woman is decided that she will require radiation, we first bring them for a simulation. So simulation is the process of positioning the patients, making marks on their skin, and taking imaging scans, typically CT scan. And then it's radiation oncologist's job to outline the target. It includes the breast, chest wall, lymph nodes, whatever you feel appropriate to treat. And then normal tissues, primarily lung and heart. And then we have a team that put on the radiation beams to create a plan, and that's tailored to the target while sparing the normal tissues. And then the patient comes in for the treatment, usually under some type of image guidance, and then we do monitor them for both the acute and late side effects. So for the simulations, I mentioned that we position the patients. That needs to be a reproducible position, and we typically position the patients in the supine position that is comfortable and typically more reproducible. And so we usually have a breastboard and then a vac lock to immobilize their elbow and arms. The only downside of it is for women with large breasts, usually if they're laying flat, there might be some overlap of tissue in the inframammary fold. Alternatively, they can be simulated in the prone position. We currently don't use the prone board anymore, and it's not as reproducible. But however, it is a great option for women with large pendulous breast. And then we contour. So if a woman had a lumpectomy, then we outline that cavity as well as the breast. If they had a mastectomy, then we outline the chest wall, which includes the skin, the subcutaneous tissue, the pec muscles, and the ribs and intercostal muscles. Depending on their nodal situation, we'll also outline those lymph nodes. There are several contouring atlas available from RTOG, Astro, etc., really giving good guidance on what should be outlined for the nodal irradiation. And then we put on the beams. So this is an example of a woman with right breast cancer that we put on the 2 tangential beams to treat that right breast. We look at the dose volume histogram to look at the dose coverage. As you can see that for a right-sided breast cancer, the heart barely receives any dose. However, heart toxicity is a concern for women with left-sided breast cancer. So for women's left-sided breast cancer, we now pretty standard to do this technique called deep inspiration breath hold. So as you can see, without deep inspiration, that a little bit of the heart would be included in the tangential beam. So we instruct the patient to take a deep breath and hold it. So with that deep breath, the diaphragm really pulls the heart away from the breast and chest wall. So we deliver radiation only during that phase. That really helps us to minimize the dose to the heart and lung as well. And there is camera and different system to monitor the chest position. And so a few decades ago, and at least when I was trained, that we still did some 2D planning. You sometimes draw field on the patient's anatomy or a simple X-ray films. So that can potentially lead to cardiac and pulmonary toxicities. And we do small amount of radiation every day, and the treatment course is typically 5 to 6 weeks. About 1 or 2 decades ago, we started moving on to 3D planning, where we perform a CT scan. This allows us to really see the anatomy well and improve the toxicity profile. And there are several trials that establish that, giving a little bit more radiation every day and to allow us to complete radiation 3-4 weeks is just as effective. And then about 5 years ago, data started to emerging to show that even a 1 week or 5 fraction treatment is feasible in some patients. So what are the side effects of radiation therapy? We typically think of side effects in terms of acute and late. So acute side effects are the side effects patient experience during the treatment. They usually resolve fairly quickly after the treatment is complete. So that includes fatigue, skin reaction, breast edema. Late toxicity, there is a slew of them. But I want to emphasize that with modern techniques, debilitating late toxicities are pretty rare, and lymphedema risk is very low if they only had sentinel lymph node biopsy, even with nodal irradiation. And so this is a patient I treated in 2017 to the right breast. She got the 3 weeks of radiation plus a boost. Pretty standard. I saw her just a few weeks ago for follow-up, and so that's 8 years later. You can see the right breast is slightly smaller, so there's some asymmetry. However, in terms of the skin and the texture of the breast, it really is minimally different from the other unirradiated side. And so just 2 slides on the pelvic row radiation. So occasionally patients do present with a large neglected fungating mass. This is a 70-year-old female patient of mine that presented with just that, was biopsy to be invasive ductal carcinoma, received systemic therapy. Unfortunately, primary disease still progressed. She went to the ED multiple times for bleeding and despite embolization. So we decided to give her some radiation to this breast mass. 13 treatments. This is what it looks like at the end of the treatments. And I brought her back 10 days later for a follow-up. You can see there is regression of this breast mass, except maybe for the superior aspect, there's still some viable tumor because her skin looks good. So I gave her some additional radiation just to that upper part where there's still viable tumor. This is the last day of her boost course, and this is what she looks like 5 months later. So that open wound completely closed. So that patient eventually still died from the metastatic disease, but her quality of life really improved with the radiation therapy and just so radiation is pretty effective in stopping the bleeding and drying up the oozing from the fungating breast mass. And commonly used regimen is about 10 to 13 fraction course. I think that's all I have for a quick overview of the radiation therapy for breast cancer. I'm going to stop share.
Wonderful. Thank you very much, Dr. Yuan. I don't see any questions in the chat or in the QA or hands up, but I'm not very good at all the Zoom stuff. So if anybody has any questions for our 2 outstanding speakers, why don't you let us know? I'll give everybody a little second here.
So I'm going to read that question. Regarding the radiation therapy for DCIs based on the RTOG trial, some radiation oncologists recommend radiation even for low-risk DCIS. So what is your opinion on it? Leaves room for discussion. Yeah, absolutely. That's a great question. So I think the context of is RTOG 9804 and that ECOG trial was done in an era where the radiation was still 5-6 weeks long. And then we didn't have all the advanced techniques such as deep inspiration breath hold. So there's that discussion of toxicity versus the small benefit. And now there is a trend to really bring the patients for radiation discussion because we can do radiation 5 treatments. We can do partial breast radiation. We have DIBH, so the toxicity is much, much lower. So that, it's really not a whole lot of investment for a patient to come to our department 5 times, 20 minutes each, and then they have that benefit. So there is, but so patients do have options. It's perfectly reasonable to omit, but if they do want local control benefit, and now it's so much easier.
Wonderful. Thank you. And Dr. Hunter-Squires, there's a question about targeted X-ray node dissection. I wonder if you can, they wanted just a little bit more information about that.
Sure. And targeted axillary dissection, again, is the term we use for sentinel lymph node biopsy in conjunction with removal of a previously biopsied node. And in the setting of 1071 post-neoadjuvant therapy patients who converted from clinically node negative to node positive to node negative by palpation, this decreased the false negative rate, so it made it feasible, right? And so in patients who are getting neoadjuvant therapy, who have palpable, in one disease, and then it's not palpable anymore, this is the standard is that you would find a way to localize that. So hopefully when a biopsy is taken of that node, a clip could be left, and that you can either find on an ultrasound or that you can localize with some other technique, a wire, or some places are even doing tattooing of it. you can also use kind of advanced localization techniques, which are more expensive, but again, dyes can be used. So retrieving that node that was previously biopsied and making sure there's not cancer in it is helpful in increasing the accuracy of the sentinel node biopsy in that setting. And so that's what's meant by targeted axillary dissection. I think there's a lot of interest in saying, could that be successful in more settings than that right now? But I think we're waiting for some data that should come out next year to know, can we really avoid completion axillary lymph node dissection, even for patients where there is residual disease. But again, right now, this is just for patients who've had neoadjuvant therapy, no longer at palpable nodes, and we remove this. If there's any residual disease, we move on to completion axillary dissection. But targeted axillary dissection, or TAD, is just a fancy term for a sentinel node biopsy and removing a biopsy node.
Thank you, Dr. Dredd. I see you're on your way to the OR. We're going to continue asking you questions.
Sure.
We have a question about after a lymph node dissection, Dr. Yuan, how can you avoid, or do you avoid, axillary radiation? Maybe you could talk about the combined lymphedema risks with both lymph node dissection and with radiation to the axilla.
Yeah, so there's a really good study coming from Mass General Hospital. They looked at the lymphedema risk. So typically, I don't know what surgeons quote for sentinel lymph node biopsy, the lymphedema risk is not zero. It's probably less than 5%. If you had a lymph node dissection, or sorry, if you had just a sentinel lymph node biopsy, even in the setting of giving nodal irradiation, the symptomatic lymphedema risk is only 10%. It's pretty low, it's not zero. And then in their study showed that if you did the dissection without nodal irradiation, that risk is about 20%. And the worst situation is certainly the combination of both. That would be a roughly 30%. So it's really easy to remember 10, 20, and 30. So in women who had a dissection, if they were only found to have 1 or 2 nodes, the benefit of adding the nodal irradiation is small, but it's there. So as I showed in the meta-analysis, it's really about 2 to 3% breast cancer mortality benefit. So you could consider whether that's worthwhile to do the nodal irradiation or not. If a patient had an adequate dissection, I usually avoid treating the axilla. If you had a good clearance, then I do add the superclave and internal memory nodes. If you want to treat in that scenario. But if a patient, for example, you remove 20 nodes, 15 are positive. So then you do worry that in the axilla, despite that dissection, there might be some residual disease. So in that case, I would include axilla in addition to internal memory and superclave nodes.
My comments on this as a surgeon are that, again, this is going back to where we talk about patient values and doctors' values, right? Which are not always the same. And so being able to communicate the information about, what has survival benefit and what percentages and things like that, actually, for some patients can be overwhelming. For others can be like, okay, this makes sense. This is valuable to me, or this is not valuable to me, and can help guide that decision, because I do think there is room. There are some radiation oncologists that are very aggressive, and any benefit on paper will lead to a recommendation to do that. And I think when you get more than one positive node, you do get into that setting where there is the data there to support doing it. And so it is hard to avoid. And so I would say the way to avoid it is to do more clinical trials that can tease out some of those other outcomes as well, and help kind of inform our practice a little bit more. And we think of the setting where we have patients who can have no axillary surgery and no radiation because their disease is low risk, and think about how can we expand the number of patients who are surviving from their cancer and having a good quality of life because their morbidity is less. But that is a setting where so many of our axillary dissection patients go on to get radiation, because we're really trying to reserve axillary dissection for patients who actually have a high burden of disease. So when you have a high burden of disease, both are going to be helpful.
Well, thank you very much. I don't see any other questions or comments? I'm a little bit over already. I want to thank our two speakers who did a great job today. That's a lot of work, bringing that, doing these presentations. I really appreciate your work. A couple of announcements. One's the Breast Fellowship. If you're interested, feel free to reach out to me as well. Lorene just put a note in the chat. And our next Global Breast Cancer Seminar is October 7th. We're going to have a discussion on pathology techniques and a discussion on treatment of ductal carcinoma in situ, which will be an extension of what Dr. Yuan was talking about earlier. So thank you, everybody. Have a great morning, afternoon, or evening. Bye-bye.